Hi, I'm Dr. Pamela Morris. I'm a preventive cardiologist at the Medical University of South Carolina in Charleston.
Hi everyone, I'm Bob Eckel. I'm a professor of medicine emeritus. I'm an endocrinologist, but also in joint appointment cardiology for several decades. And ultimately, I've had the privilege of working with my colleague, Dr. Christie Ballantyne, as co-chair of this meeting for 17 years now. And it's been fun to be part of it in terms of its organization, but it's even been more fun to learn from all my colleagues and friends.
And I'm Christie Ballantyne. I'm a preventive cardiologist at Baylor College of Medicine in Houston, Texas. And it's great to be able to talk about the interface. I've always, Bob and I always loved lipids, but it's also to learn from him in terms of this obesity, diabetes, and how all of this integrates. But let's talk one about a kind of a really exciting area, inflammation and lipoproteins. And we go back to the, some of the initial thoughts that going back to Virchow in terms of cholesterol, inflammation, and Nitschkoff first described foamy macrophage. Mm-hmm. So this issue of lipoproteins and atherosclerosis, I think the LDL story has been the most straightforward one, right? I mean, low-density lipoproteins being atherogenic in, foam cells and macrophages. But Pam and Bob, what about the lipoprotein A story now? And inflammation and oxidized phospholipids. You want to talk about that a little bit?
Well, so I think it's incredibly important recognizing that lipoprotein a is obviously recognized as not only a cholesterol-carrying, ApoB containing particle, but that little A tail on there is an inflammatory component, as is the cholesterol content of the particle as well. And I think we've been slow to measure it. We've been slow to develop therapeutics for lipoprotein a, and we are at a really exciting point now that we are able to develop drugs that hopefully at least can lower LPA. Next, we just really have to understand if that will lower cardiovascular risk.
Bob, there's this issue. You've got the lipoprotein A particle. And I know Sam Samika's done a lot of work with oxidized phospholipids with Joe Whitson. Yeah. But the other one is it's not just in the arterial wall, the aortic valve, and this calcific process. Do you want to comment on that?
Well, right, the association's been well known. The mechanism's a little less clear, but likely involves inflammation. I mean, the aortic valve, you guys know better than I do as preventive cardiologists, the aortic valve just doesn't get calcified and get insufficient or stenotic. It gets diseased first, and that's always inflammation. The interesting thing about LPA is, Pam alluded to this, it's an acute phase reactant. Mm-hmm. So, we used to measure SED rate, now more recently HSCRP or SAA, but now LPA does go up in acute infection. So it's an acute phase reactant, but people who have genetic elevations of LPA, which is the most common by far, really have ongoing evidence of inflammation by LPA. I mean, we're not suggesting you measure lipoprotein a to assess inflammation, but it is keeps company with other acute phase reactants.
It's interesting from a prevalence standpoint. There are likely more persons with elevated lipoprotein a than there are patients with FH, familial hypercholesterolemia. So as dangerous as the lipoprotein a particle is, it really is important that we begin to assess this in patients.
So mostly driven by genetics, and as you said, about 1 in 5 people have a high level, and it's due to genetic variants. Secondary causes can be, like nephrotic syndrome. You can get a very high LPA with
hypothyroidism, severe renal disease.
That's correct.
Yes,
so,
anyway.
but usually it's genetic, and that's the one where you have the lifetime risk. A lot of exciting therapies in progress. Still a lot of science to really understand, so as you said, Bob, the mechanisms of why do we get the disease in the arterial wall and in the aortic valve. And then we'll have to see is this treatment, and that's what, of course, the exciting part is these new, biotech getting in there, and ASOs, siRNAs, and it's targeting these things to reduce levels dramatically. It's a very exciting area.
Well, the other thing that's occurred with LPA, which in part relates to the pro-inflammatory nature of the molecule, is the whole issue, is this really prothrombotic or antifibrinolytic? Right. And so the idea of elevations in LPA also affecting clot formation and or lysis is really, and by the way, that's kind of a confusing area. And hopefully maybe this afternoon we'll be touching on that a little bit, but it certainly should be covered next year at the annual session.
Yeah, and we'll get more data out of these ongoing trials, which are going to be pretty robust, and there's more in the pipeline. Well, now we get from complicated to even more complicated, triglyceride-rich lipoproteins. And so one of the things, though, it is, first of all, and I know I like to make this thing is, when you see a high triglyceride, don't forget that's actually carried in lipoprotein particles. Because I do think that's one of the confusing areas. Is it the triglyceride or is it the particle that's causing problems? Because those are two different concepts. If you want to just touch on that, Bob.
Well, I think this is really an important thing to consider clinically, because the clinical decision making relates to the fact that the association between hypertriglyceridemia and cardiovascular disease is substantial. We can't ignore that association. And Christie and I may disagree a little bit on this as to whether triglycerides cause heart disease, but the idea is that this VLDL particle, which is the nascent or particle made by the liver, is loaded with triglyceride. And it gets metabolized downstream to a smaller particle by an enzyme I spent much of my career on, lipoprotein lipase. And that reduction in the triglyceride content does very little to change the cholesterol content of the particle. So now we're in what we call a remnant particle, or if you look at in fasting plasma, an intermediate density lipoprotein. These particles are more cholesterol enriched. And that may be why there's an association of triglycerides that are in VLDL, but it's maybe more the cholesterol content that relates to the atherosclerotic risk. Christie?
So this is the issue. If you think of the particles, I think it begins to, it makes more sense because, for example, if you had a fibrate to a statin, it turns out you didn't reduce ApoB at all, so the number of particles didn't go down at all. That maybe puts a little clarity. Now, it does make things more complicated because it may end up being that some of these particles, particularly, turns out what you worked on is this pathway of lipoprotein lipase. The genetics show that if you screw that up, you're in trouble for heart disease. In terms of the genes that have been shown out to be, ApoC3, LPL, basically look at the ANGPTL3, all the ones that are involved in some aspects with lipolysis, if that's delayed. So the other thing is particles hanging around a long time. Those particles interact with LDL particles and HDL particles, so you get screwed up lipoproteins. And it's also associated with more inflammation. And all of this, we don't have it all. It's a very complicated area, but we know that people with high triglycerides have high events. They do have more inflammation. Of course, there's more obesity and diabetes and insulin resistance.
Well, Pam, that makes me turn to you in terms of thinking about this as a cardiologist in the clinic. I mean, we see triglycerides at 250 or 300. Often metabolic syndrome is a more complex relationship between these various factors that we add up to make the metabolic syndrome diagnosis. But inflammation is probably also part of the metabolic syndrome, as is the prothrombotic state, as is fatty liver disease. I mean, the metabolic syndrome, which is a paradigm of insulin resistance, relates to triglycerides and to some extent inflammation.
And CRP, right?
Yeah.
Right.
Yeah.
Well, that sort of brings me back. This conversation sort of makes me think, drive us back to this morning's session, where we were really talking a little bit about strategies to reduce inflammation based on lifestyle. Great talk by Pam Taub on nutrition, also bringing in inflammation in the gut biome, the microbiome. The role of exercise, the role of inflammation in fatty liver disease. Really a fascinating session this morning, and really targeting inflammation through lifestyle.
And what ends up happening is we do have these issues now where in these patients, when you see that high CRP, do other therapies have benefit? We saw the data with canakinumab. There's been some data based upon ACS and coronary disease with colchicine. Just maybe some comments in terms of where do you think this is going?
Well, I've often thought, one of my favorite things about this conference here that we're currently at is the unifying concept of inflammation. I mean, you just have to realize that it is absolutely unifying that all of these cardiometabolic conditions are influenced by inflammation. The biggest difficulty we've had with inflammation is really identifying treatments that will have broad use in clinical practice. So we have canakinumab, which is really not available for cardiometabolic inflammation. And we have colchicine, which is problematic in and of itself and has some drug interactions with other drugs that we use in cardiology. So it's a bit of a difficulty. But my thought on inflammation is unless we understand it and we know how to measure it, we can't begin to target it and treat it. So this conference really is dedicated toward understanding that unifying concept.
So it's a lot more complicated than CRP, which is just an acute phase reactant. And it's not, CRP is not the same as IL-6 and TNF-alpha and IL-1 beta. All right, we better, Bob, one thing that comes back is though, in terms of, you've talked about obesity and metabolism, but I'm wondering, maybe just weight loss is going to be the best anti-inflammatory therapy.
I've been involved with a small group looking to get the NIH to support a clinical trial looking at cardiovascular disease outcomes with bariatric surgery. And that began to be entertained at the time COVID-19 began. So the NIH was not particularly interested in terms of the diversion of funds into such a study, which is not cheap. But now I don't think you can do a study like that without a drug comparator.
Yes.
Because, high-dose GLP-1 receptor agonists or dual agonists like tirzepatide really can cause up to 22% weight reduction. I mean, the average is around 15 to 18% for semaglutide high dose and a little bit higher for tirzepatide. But nevertheless, I think now, rather than referring our patients to surgeons, I think we need a trial that really does that kind of comparative analysis. So as part of weight reduction, there's reduction in inflammation. And how much that plays into the other benefit, such as the liver, I think likely does, lipoproteins, certainly it does, and probably the outcome, atherosclerosis, plays another.
So we start talking about lipoproteins and inflammation, and we end up talking about metabolic syndrome, obesity, and that's because it's all interconnected. And so really, cardiology and endocrinology, as I'm finding out, their fields are so intertwined with it, along with renal disease, liver disease. So it's one of the great things about the CMHC, and we hope that you'll attend our future meetings.